Hello and good afternoon, everyone at Butterfield Trail. So we have again our presentation for this month on healthcare topic of relevance, I believe. So today we have a presentation on anemia, which I think has been one that has in the past attracted a lot of attention. People know a fair amount about anemia, but not a lot of the details, and especially of how it affects older adults. So I think this is timely and will be helpful, hopefully. So welcome again. As you know, we have resident physicians here with the UAMS clinic here on campus, and so every 4-week block in their education, there are 2 residents here. And this month, our 2 residents are, come on up, guys, and I'll introduce you. At this point, because we've been doing this almost 3 years, 2.5 anyway, we've had residents rotate back, and both of these residents who've been here this month have been here in the past, and so have become quite familiar with Butterfield Trail, and they would tell you, have told me that they've really enjoyed being here for a lot of different reasons, not the least of which is the quality of interaction with the people who live here, our patients. So it doesn't surprise me at all that that's been a really positive thing. And when you think about it, it's been a positive thing in their education track. So I'm very pleased about that, and glad to introduce these 2 again. So at the far end here with the mask on is Dr. Aysam Mahmoud, who's from Florida and is in his 2nd year, about to finish his 2nd year here in a couple of months of residency training. So just as a reminder, these are residents who've gotten their MD and then started this 3-year residency program. So he's 2 years beyond his MD and 1 more year before he's in practice beyond training. So that's great. He's not actually presenting today. He's here in support of Dr. Calcagni, who is presenting. He's going to be the guy, if you call in, you give your questions to for Dr. Calcagni and for the group of us if you have questions about anemia as we go. So with that said, let me just remind you the phone number if you were going to call in with a question is 479-200-9259. I'll repeat that later after her presentation, but you could call in anytime. He'll take it, write down the question, and when she finishes the talk, you will try to answer the questions. But that's the number, 479-200-9259. Okay, with that said, let me introduce Dr. Calcagni, who is presenting today. So Mikaila Calcagni is a native of Northwest Arkansas. She grew up and graduated high school in Bentonville, went to the University of Arkansas undergraduate at UAMS for medical school, and she's one of these who you've been hearing about for a few years, who did her first 2 years of medical school in Little Rock, and then did her last 2 years, the 3rd and 4th year of medical school up here in Northwest Arkansas. So she was one of the first to do that. She's a 3rd-year resident, meaning that in 2 months she finishes her training altogether. In fact, she already has a job, and I'll brag on her a little bit. She's been one of our really outstanding residents who, in fact, this year is in the co-position of chief resident, which is an honorific job, but one that's kind of thankless too. It takes a lot of extra work. But she's been one of the 2 chief residents, which is a very great distinction in any residency program. And she has achieved so much, she caught the attention of Highland Oncology, who has created a position just for her, I tell her, but a very creative position of having a hospitalist. We all know what hospitalists are nowadays. These are the doctors who work full-time in the hospital taking care of only inpatients. And she will do that exclusively with Highland Oncology. So if a person were a patient of Highland Oncology starting this summer for the first time, if you were a patient of Highland Oncology and had to be admitted to Washington Regional, likely your doctor is going to be Dr. Calcagni. And I think that's just a very creative position to create for Highlands, but it's also, they found the right person to do it because she's really outstanding. So with that said, let me introduce Dr. Calcagni. She's here her third time, and is, you know, after Friday will not be back here again, which is very sad for her. Sad in a lot of respects, not the least of which, the first time she was here 2 years ago, actually October of 2019, she was 9 months pregnant, had to leave Butterfield Trail 2 days early to go have her baby. And Preston's now growing like a weed, and young man, smiling all the time. And so she's been one of those remarkable people who could actually do something like medical residency training and raise a child. So she's pretty remarkable that way. But her topic today is anemia in older adults, which is a, you know, it's a common thing, but it's not part and parcel of aging. And it's a common thing, but it's also always an important thing to know about and to not miss. So she's going to fill us all in on that. And thank you, Dr. Calcagni.
Well, that was quite the introduction. Hopefully I can live up to all of those kind words from Dr. Wright. It is such a pleasure to be able to give this presentation to you all today because, like Dr. Wright said, this is my third time here. And since I was chief resident, I got to make the schedule. So that was not by accident. I love being out here, and any opportunity I got to be here, I made sure that I was the one that was here. So thank you all for tuning in on your TV, on the internet, those of you that are right here. And like Dr. Wright said, we'll take questions. The phone number again is 479-200-9259. So we're going to talk a little bit about anemia in older adults today. And this is a topic that is very near and dear to my heart because, like Dr. Wright said, I'll be working at Highlands Oncology. So what is anemia? First, we need to define what anemia means, because this is a really common term that tends to get thrown around. People may hear you have low blood counts or you're just a little bit anemic. So let's define what that really means. All right, so the official definition of anemia is hemoglobin level below the normal range. Well, that doesn't tell us a whole lot now, does it? So hemoglobin, these are the red cells that make up part of our blood. The main goal of hemoglobin is to transport oxygen from our lungs elsewhere in our body for organs, tissues, to use that oxygen to perform the duties that they need. And then the World Health Organization gives us a pretty strict definition of anemia that says if your hemoglobin is less than 12 in a woman, you're anemic, and if your hemoglobin is less than 13 in a man, you are anemic. And hemoglobin is something that we look at on just a normal CBC blood draw. So this is a really simple test. We take a little sample of your blood, and we can measure the hemoglobin concentration. So a little bit of epidemiology. The incidence of anemia increases with age. So incidence is just the number of new cases of a disease that happen. In community dwelling adults over the age of 65, my numbers are really small, 10.2% of women have anemia, and then 11% of men. So that's quite a big amount of people. If we got 10 people in a room who are over the age of 65, at least one of them would probably have anemia. And then as our population ages, that number is only going to increase. And then in adults over the age of 80, 12 to 16% of women and 18 to 22% of men, so about 1 in 5, is going to have anemia. And then over 50% of people who live in a long-term care facility will have anemia as well. All right. If you learn nothing from me or take nothing else away, let this please be the one thing that you remember. Anemia is never age appropriate. So all adults who are found to have a low hemoglobin need to have this investigated further. So I feel like a lot of people may say, well, your hemoglobin's low, but that's appropriate for your age. It's not. There is no age-appropriate anemia. So what does anemia look like? So this is how the anemia is going to manifest itself. So anemia is thought to lead to what we call a decrease in cardiac output. Cardiac output is just a really fancy term for how much blood our heart is able to push out with each beat. So that doesn't sound good to anybody, right? Decreased blood output with every beat. It can also cause local tissue hypoxia. So like I said, hemoglobin loves to transport oxygen. And so if we're not pumping out enough blood and we don't have enough blood, all of the tissue is not going to get enough oxygen. So it's not going to be able to perform all the duties that we need it to do. It also can cause an aggravation of other chronic medical conditions. So this can be a worsening of your COPD or chronic obstructive pulmonary disease. It can be worsening of your congestive heart failure. All of these chronic medical conditions that can come with aging can be worsened by anemia. And then it can also cause a functional decline. So the reason that this happens is, like I said, if we don't have enough blood, we don't have enough cars to transport oxygen where we need it. So we're going to be tired. That's going to cause us to become less mobile. And then if we start to become less mobile, we become deconditioned. So just having a low blood count can cause us to become deconditioned and cause a functional decline. This is also associated with impaired performance-based mobility function. And then women over the age of 65 with a low hemoglobin have been shown to have a higher risk of all-cause mortality than those with a normal hemoglobin. And that's completely independent of any other factors, any other diseases that you may have or comorbid conditions. So just having a low hemoglobin as a woman over 65 is kind of an independent risk factor for all-cause mortality. So what are some of the signs and symptoms? So all of these tend to be related to poor oxygen delivery, fatigue. This is just going to be that feeling of, I don't have the energy I used to have. It takes everything I have to get up, walk to the bathroom, brush my teeth, get dressed, and it just completely takes everything out of me. Shortness of breath. Now this shortness of breath is mostly going to be with exertion. So as you start to walk to the car, walk around, do physical activity here at Butterfield, you'll start to notice you get a little more short of breath than you used to. Now, if you ever have shortness of breath at rest, that in most cases is going to be a medical emergency, and we can tend to see that with people who have such a low hemoglobin that even talking gets them out of breath. It can cause generalized weakness because our muscles require oxygen to work. So if we can't transport oxygen, our muscles get really tired and kind of want to give out on us. Sometimes you may actually have visualized blood loss. So whether that is brisk bleeding from your bowels or a trauma that causes a lot of blood loss, you may or may not see some visualized blood. It can also manifest itself, like I said, as an exacerbation of your chronic medical condition. And then also, some people may not even realize they're anemic. It may be their significant other or a family member that notices. They may say something like, you seem a little more pale than normal. Our hemoglobin kind of gives us that beautiful red hue that we tend to see. So if we don't have that, we can be a little more pale. And the best place to check for pallor or paleness is actually pulling down your bottom eyelids and looking at the conjunctiva, because they will be stark white if you are anemic. But please, please, please don't think that if you're anemic, you're going to have symptoms, because anemia may be a very slow chronic condition instead of something acute or abrupt, meaning you may just not have any symptoms at all. So this is a really great reason and a really great plug for us to remind you all to please, please, please follow up with your PCP at regular intervals where they check blood work, because our bodies are really miraculous. They're able to endure a lot, and they can be like a slowly depleting hemoglobin. So you may not even know until you follow up with your PCP and he does a blood draw and you're noted to be anemic. So what are some of the very common causes in an aging population? So about a third of people who are anemic, it's going to be to a nutritional deficiency. This can be vitamin B12, folate, iron. Those are some of the big ones we tend to think about. Another third is going to be due to a chronic inflammatory condition. Think rheumatoid arthritis or chronic kidney disease. And then unfortunately, a third are going to be due to another cause, or we're just not going to be able to figure out the cause. All right, so this is where it gets really good. How is anemia classified? So I like to remind people to think of anemia and how our blood is produced like a factory. So some of the main causes, the first one is poor production. So our bone marrow, which is housed in our bones where blood is made, just doesn't produce enough red blood cells. So think of a factory that just doesn't make enough product for the demand. The next is an intrinsic problem, so a problem within the red blood cell itself. So the cells produced are just a little defective. The factory makes a faulty product. Next is an extrinsic destruction. So something outside of the red cell itself is causing it to be destroyed. So think a factory puts out enough product, but there's something that's destroying that product or destroying the trucks that deliver the product. And then finally, blood loss. So this is going to be a literal loss of your red blood cells, whether that be external or internal. And so think the factory just has all of its products stolen. So let's start by talking about poor production or an intrinsic deficit. So these are not an all-encompassing list. These are just the most common things that we would see in older adults. So just because I don't mention it doesn't mean it doesn't exist. So the big ones we think about are iron deficiency, B12 and folate deficiency, myelodysplastic syndrome, and anemia of chronic disease. All right, so iron deficiency. So this is most commonly due to a poor diet, but it can also be due to a very slow blood loss. So a lot of people have probably been told you need to keep up with your colonoscopies. This is not everybody's favorite thing to do. However, if we have a polyp or a just new budding cancer somewhere in our colon, they're very friable. And so they like to just slowly ooze blood. And as we lose blood, our body gets the signal that it's time to ramp up production. And so we use all of our iron stores because we just want to make red blood cells. That causes us to be iron deficient. B12 deficiency, so this takes a very long time to develop. Think like 3 years. So this is going to be 3 years of a very poor diet, or people who are chronic alcoholics and tend to get all of their calories from alcohol instead of food. Folate deficiency can happen a lot quicker. So this happens in as little as 3 months. And it tends to be just due to a very poor diet. So the common test question we get asked is somebody loses a spouse, they get depressed, they don't really want to eat, all they're having is tea and toast. That's kind of our buzzword that we hear is tea and toast diet. And so they become folate deficient. Also, some medications can cause you to become folate deficient, like methotrexate. Myelodysplastic syndrome is where the bone marrow where our cells are produced actually just becomes fibrotic. So if it's fibrotic, it can't produce what we need it to produce. And then there's just no space to make new red blood cells. And then finally, chronic inflammation or chronic kidney disease. Our kidneys are really remarkable organs. You'll probably hear me say our bodies are remarkable anyway. God created us in just the perfect way to make things work. But our kidneys are great at producing a molecule that stimulates our bone marrow to make more blood. So if we have diseased kidneys, they lose that signal, so we no longer create blood like we need it to. And then chronic inflammation, it just causes inflammation all over the place, and our bone marrow is very susceptible to that as well. All right, so what are some of the signs and symptoms of poor production? So iron deficiency, you may find out you're iron deficient just incidentally. You may go and have your blood drawn. The doctor says, you know, your hemoglobin came back low, so I added on an iron panel, and it showed that your iron is low. So it may just be something incidental like that, or you may possibly see changes in your stool. So this can either be bright red blood or very dark, thick, tarry, coal black stools. So if you ever see a change in your bowels, either bright red blood or dark, tarry, sticky, coal black, that needs prompt evaluation by a doctor. B12 deficiency may present as depression. It may present as memory impairment. It may start to present as numbness and tingling or weakness in your extremities. Folate deficiency can also present as a memory impairment, or people tend to be on a very high-risk medication. Myelodysplastic syndrome, now, there's really no signs or symptoms of this. This tends to be found when the easier workup for anemia comes back clear. Everything's normal. So then we start to look a little deeper, and then we find that you have fibrosis in your bone marrow. And then anemia of chronic inflammation, it's just going to be a personal history. Do you have any chronic inflammatory diseases? Do you have kidney disease? Things like that. So how do we work up anemia due to poor production or an intrinsic deficit? We always want to start with a CBC, which is doctor shorthand for complete blood count. This is a very easy blood draw, and we can take a look at all your cell lines, your platelets, your white cells or your immune fighting cells, and your hemoglobin. Sometimes we also want to take a sample of that blood and look at it under a microscope. So a peripheral smear allows us to do that. We take a drop of your blood, make it really thin, and then use a microscope to look at the cells themselves. That can also help us determine what they look like, how big or how small they are, and that can lead us in certain directions. We can also get an iron panel. So this is a way for us to check your current iron levels, but also your iron stores. This also is just an easy blood draw. We can also check B12 and folate like we do with a normal blood draw. We can look at some of your inflammatory markers if we think it may be due to inflammation. And then last, if all of this comes back negative, the easy blood draw things, we may want something called a bone marrow biopsy. So this is where they take a little sample of your bone marrow and look at it under slides. So how do we treat this? So for nutritional deficiencies, we just replete what's missing. We normally give iron. It's much easier tolerated in oral form, and most people do great with just oral iron replacement, but there is IV formulations if we do need those. And then if you're B12 or folate deficient, we really do just replete it, and most of that tends to be oral or with a B12 injection. I am of the camp that it is not a bad idea for everybody, no matter your age, to be on daily B12 and folate supplements. Myelodysplastic syndrome. Now, there are a few ways we can treat it, but most of the time it's just treated symptomatically. So that would be with frequent transfusions and medications designed to kind of poke your bone marrow and urge it to produce whatever it can. Treatments tend to be things like stem cell transplants, but most of the time people do really well just managing their symptoms with transfusions and medications that can boost our bone marrow. And then if it's anemia of chronic disease or inflammation, it really goes back to getting that condition as under control as possible. So your chronic kidney disease, your rheumatoid arthritis, getting all of those things under the best control we possibly can. All right, moving on to extrinsic destruction. So your bone marrow has made cells, they look great, they're just getting destroyed by some external factor to the cell itself. The things we're going to talk about today are medication-induced, which medications are great, but nothing is without a side effect or a potential side effect. So medications tend to be one of the biggest things we see with extrinsic destruction, or what we call autoimmune hemolytic anemia, which is a really fancy term, meaning our immune system got revved up for some reason and decided to attack our red cells. All right, signs and symptoms of these. Now, in addition to the fatigue, shortness of breath that we talked about at the start, you may also see, now these tend to be very acute, so this isn't going to be something that happens over a long period of time. It's going to be very abrupt. Maybe you started a recent new medication, or maybe you were recently ill. Of course, fatigue, shortness of breath, weakness, but this is going to be so abrupt, you will be very able to take note of it. You may also see dark urine. So when our red blood cells are split open, when our immune system gets so angry at us, it attacks our red blood cells, they literally lyse and release all of their contents. That causes our urine to become cola or tea colored. And that will be something that you guys recognize very easily. You may also have enlargement of your spleen. So yet again, our bodies are really beautiful things, and the spleen has the ability to take in those damaged blood cells, but it's going to grow and grow and grow as it takes those. So you may notice your abdomen is a little more distended, especially in the left upper quadrant. Maybe you're realizing you can't eat as much as you used to, or you may just feel really full sooner than you're used to. So what does the workup look like? We always want a CBC, so we can look at that hemoglobin level. We also want to look at an LDH. So this is also something we get on a blood draw. This will tell us it's a molecule that's found in our cells, and if it's really high, we know that our red cells are being broken up. We also look at something called haptoglobin, which is a molecule in our body that binds with hemoglobin. And so if that level's really low, we know that those molecules are being used up by broken hemoglobin. Of course, I like hematology and I like oncology, so I always want to look at cells under the microscope with a peripheral smear. And then I really want to talk to my patients. This is where I really want to sit down with you and tell me what's new, what's different, what medication have you started recently, who's been sick around you, have you had even a cough or the sniffles, anything like that. Any type of illness can rev our immune system up to start to attack our red cells. So how do we treat this? Well, if it's medication-induced, let's stop the offending medication. And please ask your doctor to add this to your allergy list and put a description of this allergy so you never get this medication again. And then a lot of this, unfortunately, is what we call supportive care. This may require blood transfusions if your hemoglobin gets too low, but it's really just supporting you, making sure you have all the nutrition you need so your bone marrow can start to make good red cells again. Steroids do play a little bit of a role in this if it's due to an immune response. So if our body revs up and decides to destroy our red cells, steroids can help quell that. And then I love talking to my patients, and so I want to see you back in my clinic for very frequent blood draws so I can make sure that's trending in the right direction. Okay, the big one, blood loss. Now this sounds really obvious, right? Like clearly I'm going to realize if I am losing blood. It's not always that obvious, unfortunately. So what are some of the signs and symptoms of blood loss leading to anemia? So like I said earlier, this can be very acute or it can be gradual. So if it's acute, you guys are going to recognize this. It's going to be dark, coal black stools or bright red, brisk bleeding you can't get to stop. It's going to follow a trauma. You're going to actually visualize the blood. Or it can be really gradual. So you may be fine. Things are going fine. You follow up with your PCP. You realize you're anemic. Or it may be one day you wake up and realize, man, I just got more short of breath trying to put my clothes on. I didn't think that was happening. So I always tell people, you know your body better than me. You know yourself better than me. So I trust my patients when they tell me something's not right, something is off. So if you feel that way, please be in tune and let your doctor know. And like I said, these may be completely asymptomatic. This can be a very slow trickle, a very slow loss of blood. And sometimes our stools don't even change colors with blood loss, and you can still be losing blood in your stool, and you just can't visualize it. So if this is a very acute, sudden onset, in addition to gross blood that you will very likely see, most commonly through the GI tract, you can also have tachycardia. So your heart rate's really going to increase. That's because your heart is trying to pump out whatever blood it can as quickly as it can. So that's your heart's response to realizing, we don't have a lot of blood here, so I better pick up the pace. Hypotension or low blood pressure. Well, having red blood cells in our vessels is what helps to create that blood pressure. If you don't have enough to keep those vessels open, you're not going to be able to generate enough of a blood pressure. You may become very pale very quickly. And then this is going to be sudden onset fatigue, weakness, shortness of breath. You are going to know something is completely wrong. So blood in the stool. Like I said earlier, if you get nothing from this, anemia is never age appropriate. If you remember one other slide from this, let it be this. So blood in the stool. Not all blood is visible, like I said. Just because you do not see anything bright red or dark and tarry does not mean you have not been losing blood through your GI tract. Because like I said, those early cancers or polyps are so friable that anything moving past them is going to cause them to bleed and ooze. You may see bright red blood. The fancy medical word for that is hematochezia. I think that's what they call like a $5 word or a 25-cent word. That's one you can take home and impress people with. The bright red blood, it tends to tell us you have bleeding from your lower GI tract. So this is going to be your large intestine. So the things that normally cause this are diverticulosis, bleeding from one of those outpouchings in the colon that everybody gets with age, or hemorrhoids. And this is going to be very brisk blood, and that's why it's bright red, because it has left the vessel and immediately left your body. So it is bright red. It doesn't have time to be digested or anything like that. Melena, also called, this is the fancy word for dark stools. Now, everybody likes to come in and tell us, well, my stools are more dark. I really am going to push you and make you tell me exactly what you mean by that. We are going to get so comfortable with each other. I'm going to know a lot about you, but I want to know exactly how that's a change for you. Because most people will tell me, well, it's darker brown than normal. That's not melena. That's not bleeding. If I'm talking about blood in your stool, it is going to be, think back to when you had children. The baby's very first stool is meconium. It's just like that. It's thick and tarry and hard to clean off, and it is coal black. It should alarm you if that's what you see. That's not something we put off and say, well, maybe that'll stop, or maybe that'll go away. That needs to be evaluated immediately. So think, if you look at your stool and think, this reminds me of when my child was born, you probably want to give us a call, because this means you are bleeding from your upper GI tract. And the reason it's so dark and tarry is because it's been sitting in your stomach and sitting in your small intestine and has been digested. So it's not leaving your body as quickly as that bright red blood was. Some common causes of this are an ulcer in the stomach that starts to bleed. And like I said, if you have true melena, it is an emergency. You call Miss Robin, call our on-call phone, and come and talk to us, and we will get you evaluated. Because really, there's only 3 things that should cause your stool to be dark black, and that is bismuth, so Pepto-Bismol, iron. Iron supplements are going to make your stools black, and blood. So if you're not taking iron and you're not taking Pepto-Bismol, that only leaves one other. Now that I have officially scared everybody, we can move on to the workup. So of course, let's see where your hemoglobin levels are and get a CBC. I also want to look at your vital signs because that's going to help me make the decision, do you need to go to the hospital? Do you need to be admitted? Or is this something I can manage outpatient? And if it's very brisk bleeding, you may require some imaging to help us determine where you're bleeding from. And then you may need a colonoscopy or an EGD, which is the upper scope. So if you are found to be iron deficient, whether that's because of something like this, something very acute, or something gradual that we just found on a CBC, you need a colonoscopy. I know that's not everybody's favorite, but the leading cause of iron deficiency in the aging population is a polyp or an early cancer that is causing you to lose blood. Now, a lot of people are probably saying, well, can I just do that Cologuard test where I take a sample of my stool and send it in? That is an okay screening tool, but once you're found to be iron deficient with anemia, it's not any good anymore because now I need to find the cause of why you're iron deficient. And those tests, like I said, are great for people who don't want to undergo a colonoscopy, but they have a very high false positive rate, meaning there are a lot of positives that are not true positives because they want to pick up everybody. So if we have just a few people who truly have bleeding in their colon, I'm going to make my test really broad so I don't miss them. But in making my test broad, I've also included people who truly don't have bleeding from their gut. So if you are found to be iron deficient, you need a colonoscopy unless you just choose to not do that. So how do we treat blood loss anemia? Well, first we got to stop the cause. We got to figure out where you're bleeding and stop the bleed. This may require blood transfusions, and it may require quite a few of them. Then, like I said, depending on your vital signs and how stable you are, it may require a hospital admission. Hospitals can give you rapid blood transfusions. They can give you medications to help keep your blood pressure up. It's closer monitoring, but not everybody is going to immediately get there with blood loss. And then depending on your findings from a colonoscopy and EGD, we may have to call in some of our friends, like the GI specialist, the general surgeon, or other people to help us extract that polyp, extract that early cancer. So medicine is a team sport, so we're going to call in our friends when we need help. And then some people are just on a medication that causes them to bleed very easily, like warfarin or Eliquis. If you're on any of those medications and have a GI bleed, that deserves a conversation with your physician to talk risk and benefit. What's the risk of me staying on this medication versus what's the benefit? I've had this GI bleed. Does this cause a risk that outweighs the benefit of me being on this? So I also want to encourage you guys, please reach out to your doctors. Let's have face-to-face conversations with mask to really talk about medications you're on. Is this the best for me? What are the risks associated with this? What's the benefit to being on this? Because medications, it's like a revolving door. They need to be reevaluated frequently. Oh yeah, and did I mention that anemia is never age appropriate? So do not allow anybody to tell you your hemoglobin's low. It's fine for your age, it's age appropriate. No, it deserves some sort of a workup. All right, some clinical takeaways. Like I said, anemia is never, ever age appropriate. Even if it's just found incidentally on a yearly follow-up, it deserves to be investigated if you as the patient want it to be investigated. Don't ignore your symptoms. You guys are your best advocate. You know your body better than anybody else. If you're found to be iron deficient, it's time to have a colonoscopy. And then there's multiple other causes of anemia that I didn't go over. So if this type of workup is negative, push for more answers. There may be more things we can do to help work up the cause. These are all of just kind of the basic things and the things we see more commonly. So now for the highlight of this presentation. The phone number is 200 9259. But I just wanted to take the time to show you guys pictures of my son, Preston. He is the light of my life. My dad was actually going to watch this on YouTube, so if he saw these pictures, I'm sure he's smiling right now. My son is into The Muppet Show. He loves Kermit the Frog. He loves blueberries. He loves to laugh. He loves to make us laugh. I'm going to get teary-eyed. Being called doctor is great. It's something I worked so long and so hard for. I would give it up every single day to get to hear his little voice say, "Mama, Mama." So now I'm really going to get sad. It has been such a pleasure to be here over the last year and a half. Like I said, as a chief resident, I put myself out here for the third time, and that was not by accident. You all have really accepted all of us, not only into your lives, but into your hearts. I like to tell Dr. Wright, it feels like you all adopted each and every one of us. You get so excited when we're here. I know things about your personal lives, things about how you met your spouse. Those are stories that I love to take home to my husband and share. So it has truly been a pleasure. And like Dr. Wright said, Friday will be my last day here, but I wholeheartedly intend to come back and visit you all, not as your doctor, but as your friend. And it has been such a privilege to get to take care of you, and thank you for welcoming me into your hearts.
Fantastic. Thank you so much, Dr. Calcagni. Now you see what I was telling you is true. I was bragging what an outstanding doctor she is. She's also an outstanding person, and we know an outstanding mother. I just don't, we guys going through medical training, we don't understand and could never probably accomplish what women do with these dual roles of being a mother. It's one thing to be a father, and that's pretty important, but without the mother, that's where the real sacrifice is happening. So one last time, I'm going to say the phone number just in case there's somebody that might call in, because we really covet questions. It's 479-200-9259. So please do call if you have any kind of question. Well, I thought that was a good overview of anemia, and I hope you did too. And maybe there'll be no questions because she answered all of them along the way. I think that happens too. But I think she made a really good point of how important this is, not to because everybody's a little bit familiar with anemia, and people have had anemia off and on for fairly benign reasons. We tend to diminish it a little bit, and that's never a good idea. So she makes a really good point that it's always important to find out how, why a person's anemic. So I think you did a very good job of that, Dr. Calcagni. While we're giving it just a couple of more minutes, and by the way, you handful of people here can ask a question, and we'll repeat it out loud if you have one. But while we're giving that just a few minutes to see if there's anybody, I'll make just a couple of comments. First of all, I want to congratulate everyone at Butterfield Trail, as I've done a few times, and I want you to know I do it every chance I get, publicly and privately, to brag on Butterfield Trail for the vaccination sign up. I'd just like to see, I don't think there's any place in the country, any facility of any type in which 99% of folks signed up and took the vaccine. That's extraordinary, and it does pay off. It increases the protection here against COVID, far greater than any place else, and so that's marvelous, and I'm so very proud. I just want to congratulate everyone for doing that. I hear people who, and we all knew before COVID that there are certain segment of the population that are anti-vaxxers, don't believe in them, scared of them, don't go along with vaccines. That's hard enough for me to understand, but in this pandemic, it's some ways even harder. But I again point out that That's not the problem at Butterfield Trail. People were wise and saw that believe the science does tell us where to go and what to do right, and this is going to pay off big time, I really believe. So that's great. Also want to say that I'll extend a little bit of the gratitude that Dr. Calcagni was mentioning, and thanking all of you for the reception we've had in the 2 years we've been here, representing UAMS and a partnership with Butterfield Trail, establishing this UAMS clinic, and the round-the-clock service that we now provide. So for those of you who might not be aware, people at Butterfield can talk to a doctor 24/7 with the same number we're giving out for questions. If you have a question in the middle of the night about your own health and what you should do or symptoms you're having, that same number that I've just been offering is the on-call phone for these resident physicians. So you can talk to a resident right then, and I think that's a service that's important. Everybody who wakes up with some kind of symptom doesn't need to go to the emergency room, but some do, and some need other advice when you're having the symptoms. So that's I think an important service. We're trying to expand. We're in the process of expanding service with the clinic now as well. I thought it might have happened by this month, the month coming, April. It's probably going to be another month and a half or 2 months, but those of you who have used the clinic with any regularity know, the clinic is open 5 days a week, but the physicians are there, myself and the residents are there 4 days, with Tuesday being the exception. Tuesday, Robin, our nurse, is there, but we haven't had physicians. But very soon, at least by the end of May, if not sooner, we intend to have it 5 days a week with physicians on site. So I think that's going to be, a milestone thing in our effort to expand service here, so that you get what you need when you need it. Again, we're able to do that because of the support you guys have shown us, and I want to thank everybody for that. And I'm primarily talking about the residents who live here, our patients. Your support has helped us establish this and give us a reason to believe that we can grow here. I also want to thank the administration too. They've given us support that we've needed. So thank you all for all that. I guess, Dr. Calcagni, you really did answer questions, but there is a question. Okay, see if I do this song and dance long enough.
Oh no, we do have one question.
Yeah, look at that.
So the question is kind of two parts. One is, when should we stop doing colonoscopies? And the second part of it is, the patient is currently undergoing treatment for anemia with Procrit. They're 87 years old, and they're wondering if they should be getting a colonoscopy as they've continued to need treatment for their anemia.
Do you want to start by talking about colonoscopies and when we can stop them?
Yeah, why don't you go ahead?
Okay, so to answer the first part of that question of when can we stop getting colonoscopies, we kind of talked about this. It's all risk and benefit. Of course, with a colonoscopy, there are risks that the surgeon or GI specialist will go over with you. And so I think Dr. Wright would probably agree with this. We stop doing colonoscopies when the risk outweighs the benefit. It is not uncommon for us to have people who are 90 plus who are so healthy that we think for sure this patient's going to live more than 10 years, because we tend to have colonoscopies every 10 years if everything looks okay. So yes, I think they would do perfectly fine with a colonoscopy. So it's really weighing the risk versus the benefit. Do you have a greater risk with comorbidities, other illnesses that increase your risk for undergoing anesthesia? Or Do we think you're very healthy, you have a long lifespan? Yes, I think we need to look and make sure that you have no precancerous cells or polyps via colonoscopy. Do you agree with that?
I do agree with that, and so these risks would be like family history. If you have a number of people in your family who've had colon cancer, you know, this is a cancer that gets more common with age, not less common. Your risk doesn't go away with time. It actually increases, but especially if you've got it in your family. And then if you've ever been found to have polyps, the reason they, you know, if you underwent a screening colonoscopy and they found polyps, they virtually all would be benign, but they will remove all the polyps. Because these polyps, some of them, you don't know which ones, but some few of them have the potential for going from benign to malignant over a period of years. Now that typically would be 10, 15, 20 years before they transform, but that's why they say, okay, you're a polyp former, we're going to have you back early, like in 3 to 5 years, so that any new polyps, we remove them too. So none of them ever have a chance to turn into a malignancy. If a person has those risk factors, we're probably going to say, you know, there's a little risk to colonoscopy, but in your case, it's probably more risky not to do it. So that is the kind of thinking. And then the second part.
And then the second part, I know this will be very specific for the person who asked the question. So they said they're undergoing Procrit, which is an injection or an infusion that you can get to help stimulate your bone marrow to make more cells. And that's a discussion you need to have with your hematologist, probably at Highlands, regarding risk and benefit. So they have determined that you need to stay on that medication. And it may not be due to iron deficiency. So having a colonoscopy in your case may not help find the cause for your anemia. So I would say have a discussion with them, because Procrit is not just used in iron deficiency. You may have anemia from some other source, and undergoing a colonoscopy wouldn't help find that cause.
We had a second question. It was in terms of the diet. So specifically they said, what's a proper diet to improve or prevent anemia? So as Dr. Calcagni had mentioned, there are multiple causes to why we can have anemia. One's blood loss, but from a nutrition standpoint, we have two main types. Usually either getting too little iron or too little vitamin B12 or folate. And so depending on the type of anemia that you have, we might have to give you an iron pill, or we might have to give you some vitamin B12 or some folate. And so there is no true one diet for it, because if you have enough iron, then there's no reason for me to give you a supplement for it. And the same would apply for those vitamins. And so it's really important when we do get those lab works done at your doctor's office, when we check your hemoglobin, there are some other useful information in that lab that we take a look at to determine, is it because of low iron, is it not enough vitamin B12 or not enough folate, and then based off of that information, we're then able to give further recommendations. But typically, having good like dark greens, dark leafy greens that has like broccoli, spinach, those usually have your vitamins, your iron, so that's usually a pretty good diet there. A Mediterranean diet in general is I would say is a really, really good diet.
And red meat is not all bad.
I think that's the last question. If there are no more, I'll just thank you all for attending and for your interest and your support for us year-round. So thanks again, and have a great day.